Well, I'd like to thank the Bone and Joint Center and the physicians of the Bone and Joint Center for allowing me to come and participate in the 2018 Orthopedic Update. And based upon the time that Kevin gave me for this presentation, I'm halfway home. So we'll try to squeeze in what we can. We're going to take a look at the orthotic use for plantar fasciitis patients. And the first thing we want to do is take a look at the research. And we're going to start off with the American Physical Therapy Association's revision 2014 of their clinical practice guidelines. And it's interesting to see how the research has changed over the last couple of years, historically, in relationship to the benefit of orthotics. If you look at 2008, the literature basically said, yeah, if you want to try them, go ahead. You can use them, and they're going to be beneficial for the 3 months, but you're certainly not going to get any type of long-term effect or benefit from using an orthotic to decrease pain or to increase function. So then we fast forward to 2014, and the literature says you should use orthotics to increase function and to decrease pain. Not only did they say that you should use them, but they also increased the length of benefit from being short-term to long-term. So then we want to take the other aspect of the literature was they gave us a little hint in how to improve our performance or outcomes with the use of an orthotic. And that is to start using or pre-testing with an anti-pronation taping technique. And it's about at that point in which all the objectivity stops with the treatment or using an orthosis for your foot patient, because a lot of subjective and clinical outcomes come into play. And that's shown by, number one, the number of ways that you can use anti-pronation taping. So if we look at one technique, which is on your right, is the kinesiotaping, which is really more of a proprioceptive type of taping technique as compared to the more rigid taping technique on the left, which is more controlling in nature. So if you start off with the kinesiotaping and you don't have any success with pain relief, make sure you're working through the progression of tape jobs to see whether or not you're going to have some benefit. I just jumped to the more rigid one right away and to see if I have any benefit with that. If I do, then I think I can progress on to the use of an orthotic. Then we go to in the literature, I didn't point out, the literature said that the results are equal, whether you use a prefabricated or a custom. So to that question, I'm not sure how you should answer it, but according to the literature, they're equal in their results. But when you look at the assortment that's out there, you have a wide variety of different prefabricated or the way you can do customs. And so then it comes again to what's good in your hands, what are your outcomes, how are you going to apply the use of these devices to your particular patient. In our practices, we find that prefabricated work fairly well. If you are just dealing with some heel pain, or if you want to give a little support to the medial arch, you certainly can. A few things that you should know about prefabricated. Some of the research indicates you should have about 5.5 to 6 millimeters of elevation in the medial arch to kick in the windlass effect of the plantar fascia. And you should have a metatarsal arch. Those are the things that should be built into your prefabricated. But if you have any kinds of gait anomalies or foot anomalies, as Dr. Carlson was showing us, prefabrication probably isn't going to get to where you need to be for the success that you're looking for in your clinic. So when we approach the use of an orthotic, the very first thing we do is we approach gait mechanics. We're not going to put an orthosis on without making sure that the patient understands that we want to strive on gait mechanics that start with a lateral heel strike, going through the normal foot progression over the top of the foot, with the last 20 to 30% of your push-off coming from the first MP joint. That is a lever system that we want to bring back into play with the use of an orthosis. And so we must do the gait training to make sure that we're doing this. The plantar fascia also has to be brought into play through normal biomechanics. If we are doing compensations, which we'll show, we're not going to get the same stress that we need to go through that tissue to make it viable once again. And the plantar fascia also supports the metatarsals, and that's important for us to look at when we are applying a metatarsal arch to the orthosis. We need to give support, especially in those last phases of push-off. So then when we have these gait anomalies, or these anomalies caused by foot structure that Dr. Carlson showed, one of the things that we look at is the hindfoot, because we believe the hindfoot has a controlling factor on the rest of the foot. So the hindfoot's going to control how much the subtalar joint pronates, how we get midfoot compensation or pronation, driving us to that first ray during our gait pattern. This is an example of a person who has 10 degrees of calcaneal inversion with 0 degrees of calcaneal eversion. That's a red flag for us, because we know that without calcaneal eversion, we cannot pronate or have that midfoot pronation that we're looking for, allowing us to get to that first ray on push-off. And so we know that there's going to be some kind of compensation pattern that's going to occur. Some of the most common ones that we see is, here's an example of a person that's standing full weight bearing. They have very little calcaneal eversion, probably 1, maybe 2 degrees, and they have a significant midfoot collapse. And we believe that's a compensation pattern over a long period of time to get that first ray to the ground. And so this is a compensation that we'll see. The other one is where they have a rigid hindfoot, they have a rigid midfoot, and they have to splay the forefoot in order to have that ground accommodation and balance that you're looking for at mid-stance and push-off. So we'll see some of these, and you can see that probably not a lot of success with the prefabricated orthosis. We also see at times a forefoot varus. And a forefoot varus is when we have when we're looking at a subtalar neutral plane, the calcaneal plane, we want the metatarsals to be in alignment with that. If they are not, the first ray is elevated in relationship to the fifth ray, which means that they have to drive or work harder to get that first ray down to the ground. And so many of the old texts talk about the compensation to the forefoot varus is to have excessive calcaneal eversion. Well, if you have a rigid foot, that's not going to be the case. And so now we have these situations in which the person has to do a medial heel whip. They'll stay relatively externally rotated from heel strike to toe off, resulting in a shearing force and driving their calcaneus to the midline during push-off. And so we have these types of anomalies that occur. So with all that in mind, how do we approach the use of an orthosis? Well, if we have a rigid hindfoot, we used to try a lot of different things. And so one of the most common mistakes that we will see is that when we see a foot that has this midfoot pronation like this, and the heel is relatively in neutral position, we'll have some folks that will add a medial heel or a medial wedge to the heel, thinking that they're going to help support the midfoot and bring the midfoot back into pronation. Well, what's actually occurring is that you're wedging the medial heel, you're further restricting the restriction that's already there, so they have to work harder to get the first ray back down to the ground. So we generally, if we see that, we generally take that medial wedge off. We used to try to lateral wedge these, and all we did was shear the orthosis and just created a wear pattern there, so we don't even do that anymore. We just simply put the calcaneus in a sufficient heel cup to try to put gather as much of the fat pad as we can within that heel cup. We also then put a higher lip on the medial border of the insole or the orthosis, so that it's pushing against the medial arch a little bit with the aid of the shoe. If you don't have that higher medial wedge or that medial border, when a person steps down and they have this compensation, they're going to go against the hard ridge of a lower orthosis, and they're simply going to get a pressure ridge, and that orthosis is going to end up in their closet. And so we like to put that medial border. The other thing that we always look at is that first ray and whether or not we have a forefoot varus. We want to correct that. In our clinical findings, we see that if we correct the first ray position, bring the ground up to the first ray, that has a better chance of positioning the foot for normalized function. It's not great, but it's still better than what it generally is. And then so that's all we do. We just make sure there's a sufficient heel cup, we have a high medial border, and we correct the forefoot varus. Then, again, as stated earlier, we go right into our gait training. We make sure they have the orthosis in, and then we spend a great deal of time on making sure that they're coming over the top of the foot following a lateral heel strike. And then all the other activities and therapies that can be provided later on, which I believe Kevin will be talking about. Thank you very much.